Okay, hey, buckle up, guys. This is the cool unit. Okay, not that the other stuff wasn't cool too, but this is the cool unit. So this is our unit two, our module two or lesson two, however you want to put it. Module is a lesson, and we are going to talk all about ischemia and infarction. So make sure you've printed your note sheet, which is right here. I have it with me. I like to look at it while I'm doing this to make sure I am following along where you should be. But it's a pretty hefty packet. So notice I'm going to actually make two videos. We'll have a pause somewhere in the middle here, and you can pick it up another time, the second half. So we'll pause somewhere in the middle. I have it all set up that way, and you'll see a second video after this. I'm trying to keep them two smaller lessons so you don't sit here forever. Okay. All right. So make sure your note sheet is printed. Let's ready. Let's go. I'm ready. Let's rock. Okay, so today we'll be doing CAD and ischemia. I think you've heard of, I know we've talked about ischemia in class before. You've heard of probably CAD before, the different EKG changes that go with that, as well as any type of MIs. That stands for myocardial infarction. So that's just a fancy name for a heart attack. And there are, yes, different types of MIs. Prevention and interpretation of what they look like on an EKG, basically. Okay, so what is CAD? So CAD stands for coronary artery disease. Okay, it is the narrowing of the arteries, blood vessels, due to plaque and or hardening of the artery tissue. So that heart that we have, our heart muscle that does all our pumping of our blood, obviously, has blood vessels around it that surround it and feed that heart muscle with oxygen. If we get a blockage or a narrowing in any of those blood vessels that surround the heart, now we're not getting oxygen, blood oxygen to those certain areas of the heart, then we have a problem. So it's like Houston, we got a problem, okay? There's a lot of risk factors that come into play. A lot of it has to do with our family history, unfortunately. I have a very large family history of CAD, diabetes, hypertension. So I am on that like you wouldn't believe. So make sure I see my doctor, take any medications I need, keep my weight down, all that stuff to make sure that I stay healthy. So family history plays a big part of that. Hypertension. So if you have known hypertension that you don't treat, so like, that you have hypertension, high blood pressure, you don't take medication for it, you don't really keep track of it. How do you know if you have high blood pressure if you don't take track of it, right? So that can definitely play into it. Smoking, of course, smoking nicotine actually vasoconstricts. So it's going to cause, we know there's so many issues with smoking as it is, but this is one of them. Hyperlipidemia. So hyper meaning high, lipids is fat. This is high cholesterol is what that is. High cholesterol makes kind of our blood vessels inside kind of gummy and sticky, and it builds up like this right here, this little lipid deposit. They call it plaque sometimes, but it's lipids, it's fats, and sometimes it hardens. That's where the hardening of the arteries comes from. Obesity, just think about all the extra blood vessels, number one, we have to have when we have extra adipose in our body. And adipose, if we have more adipose, it actually constricts our blood vessels because there's so much of it, it's kind of like squeezing it. If you have too much adipose, it's squeezing other things too, organs and blood vessels. So it makes it harder to go through. Your blood pressure goes up. It actually makes narrowing of the blood vessels very common in obese people. And diabetes, and then alcohol and drug abuse. And so why is this bad for the heart? I mean, it should be pretty obvious, right? So I think I have on your worksheet, why is this bad for the heart? I'm going to take a peek, but I'm pretty sure that's what it says. Why is this bad for the heart? Yeah. You can probably come to a pretty good conclusion at this point that if those blood vessels that are surrounding the heart are narrowed or blocked, we don't get oxygen to our heart muscle. And therefore the heart muscle will die, shut down, not be able to work. Then we can't pump blood. We can't live without a heart. It has to work. So that is why it's bad for the heart. All right, finish up your notes. We're going to move on to the next one. As always, pause if you need to, finish your notes, and then pick play when you're done. All right, so this is called acute coronary syndrome. So ACS, we sometimes call it ACS. It's basically, it's the same thing what we just talked about. So it's the lowering the blood flow in the heart arteries. And this is actually a pretty good picture. You can see the arteries that surround the heart here. And then if we have plaque buildup or other things going on here, blood clots, anything that gums up the works, if you will. This is like a plumbing. So like we get a clog in our plumbing, the water doesn't drain like it's supposed to. We get a clog in our blood vessel, then the blood doesn't go through like it's supposed to. So unstable angina or angina, you can say it either way, is just a fancy name for a chest pain. Those are some symptoms that might come along with it. Something called an NSTEMI, non-ST elevation myocardial infarction, or even a STEMI. So it can lead to these, and if you have that low blood flow in those arteries, it can lead to one of these things or all of these things eventually. Unstable angina, and NSTEMI or a STEMI. I am going to explain what those are a little bit more in depth later in the lesson. I guess it's still fixated on my face. Hold on, there we go. All right. Okay, so a term angina, like I said before, angina or angina, you can say it either way. This is just a fancy word for chest pain, okay? Sometimes people describe it as a pressure, a squeezing, a tightness, a heaviness. It's all the same thing. They just feel it a little bit differently. Chest pain in the area. It is typically caused by a reduced blood flow to the heart muscle, and that's a sign that the parts of the heart aren't really just getting enough oxygen. So if we've narrowed those blood vessels, like I said before, not getting enough oxygen, we can get some outward signs and symptoms, and one of those is angina, okay? It's usually a first sign or symptom that you have some sort of ischemia or coronary artery disease happening where those blood vessels have narrowed and gotten real small and tight, okay? So a lot of people, especially gentlemen or men, when they're having angina, they feel it in the left side of the chest, and think about our apex pointing to the left armpit. So it does typically concentrate on the left side of the body. It might even go up the neck into the jaw, on the shoulder, down the arm, and into the back. Females tend to present very differently. Sometimes it's chest pain, sometimes it's just shortness of breath. A lot of times it's back pain. And they confuse that with, I just hurt my back, I laid on it wrong, I did, whatever excuse they can come up with. So I will find myself doing lots of EKGs on females that have back pain, because it presents differently in females than it does in males. A heart attack or an ischemia presents a little differently. Okay. All right, so treatments for ACS. If you have known ACS, then it's easy to just give some medications to keep it under control so that it doesn't get worse, so you don't need any medical intervention, okay? So if it's happened quite quickly, we would do these, we'd give some supplemental oxygen to help them breathe a little bit better. A nitroglycerin is going to vasodilate, so because our blood vessels are tightened and they're constricted at this point, the nitro will reverse that for us, at least temporarily. It lasts for 4 to 6 hours, usually the nitro does. So it's a little tablet they put under their tongue. There's also a patch of paste that you can put on their chest, and this will help relieve their symptoms, at least so we can do some tests and figure out what's going on in there. Sometimes if the chest pain is so severe that we might have to give some morphine. Beta blockers do help sometimes. They keep the heart rate down. So, once you start having pain everywhere, body goes into panic mode, and we do that fight or flight, and the heart rate increases. So a beta blocker can help keep that blood pressure and heart rate down while we're doing other tests to figure out what's going on. A statin is a medication given to someone with high cholesterol. So it just keeps the cholesterol on the lower level. It helps break down cholesterol in our bloodstream. It kind of breaks up into little pieces and lets it disperse and dissipate. That's the way the medications work, statins. They're called cholesterol medications. And then blood thinners, just to keep the blood thin. So if there is a blockage that's, a pretty tight blockage or a narrow blockage, then the blood thinner will help get the blood through that area without having outward symptoms anymore. So these medications are ones that were given pretty quickly. At the time when they're having that first outward signs of chest pain and they're not sure what's happening, we think it might be a heart attack. We're going to give them some medication to make them comfortable while we're doing testing and figuring out exactly what's going on inside there. And some of these, they may be on the rest of their life. Once we've done some intervention and had to maybe place some stents, or they had a mild heart attack and we don't want that to happen again, we'll fix their diet, whatever it is that's causing it, and then we might have to keep these medications with them on a regular. So a lot of people that have had a heart attack will keep nitroglycerin tabs like in their purse or on their person, so that if they start to get chest pain, they just take one and then get to the hospital. It buys them some time. It keeps the blood vessels open so that they're not narrowing so close that they don't have any oxygen going to the blood vessels or to the heart at that time. So some people carry it around with them. IV morphine is not given outside, but like statins, blood thinners, beta blockers, all something we can give long term as well. All right, so here's that fancy word, ischemia. So let's talk about ischemia. This is what our stress tests, clinical stress tests are looking for. 99% of the time we're looking for ischemic response. So ischemia is the fancy word for the narrowing of the blood vessels or the inadequate blood supply because the blood vessels are narrowed, they're blocked, they have a blood clot, a blockage, plaque, whatever you want to call it. There's a blockage in there, so it's narrowed, okay? It forces the use of glycogen reserves. Because that, it stops until glycogen stores are replenished, and then it leads to hypoxemia, angina, and increased lactic acid production, which gives you the pain. You know, the lactic acid gives you pain, right? So something's going on with the heart muscle that all these things happen, and then we end up with the chest pain. So that's our outward sign and symptom that something's happening. If all the reserves get depleted, then we have an MI. So that means we have a complete blockage. Ischemia is a narrowing, so a small blockage of the blood vessels. It can be anywhere from 50% up to 70, 80% blocked, where they won't even do anything for it. Yeah, I know. They'll just put you on some medications. So, but it can cause symptoms at that blockage. So we just have to figure out once they come in with those symptoms. Stress test is one of those tests that we can do. We give them some medications to kind of get rid of the symptoms, do a stress test and see what happens, and then see if we can see any changes in the EKG, some ischemic changes. Again, we're going to learn that very soon. So clinical observations include like what happens. Obviously, ischemia is usually caused by CAD. So coronary artery disease leads to ischemia 9 times out of 10. Okay, it does give symptoms as if you're having a heart attack. You get short of breath. You get extreme fatigue. You get dizzy and lightheaded. You get that chest pain and discomfort. It might be tightness, a fullness in the chest. You might get pain in the arms, the jaw, the running down, and your fingers might get tingly. Okay, you might feel heart palpitations. So all of these are signs and symptoms of there's maybe a heart attack, but more likely ischemia, just a narrowing of the blood vessels. It's kind of like a warning sign. And then maybe you've heard of this with strokes as well. So a full-on stroke is a stroke where you have a blood clot to the brain. We've shut off oxygen to the brain. A TIA is a trans-ischemic attack. There's that word ischemic. Okay, so that means it's a mini stroke. So it's a warning sign that there is some ischemic activity happening in the blood vessels in the brain. So our ischemia it's the same sort of thing. It's a narrowing of the blood vessels that surround the heart. So it's a warning sign. Ischemia, signs and symptoms, and then changes on the EKG are warning sign that something bigger could be happening soon. I hope that makes sense to you. Again, pause if you need to. All right, so we're talking about EKG changes. And I know on my paper here we have some nice little, I was looking at this earlier just before we started just to make sure I was on the same page. Get it? The same page. Yeah, no, I'm not on the same page. I think this is page 3. Yeah, page 3, number 8. That's where we are right now. Page 3, number 8. It has these pictures. Almost the same pictures you have on the board here. A little bit different. But there's 3 different things that can tell us whether they're having ischemia or not on the EKG. Okay, so ST depression is one of them, and or T-wave inversion. So that's 2 things. So A would be ST depression, 8A, and 8B would be T-wave inversion. There's one more thing we're going to get there in a second here. So what does that actually mean? ST depression. So that ST segment, if you take a look at this EKG right here, notice how everything comes in and out of the isoelectric line. We have our P wave into our QRST, but everything starts and ends on this isoelectric line. So when we have ST depression, depression means below. So our isoelectric line is that nice 0 on our number line. So over here we have our PQRST. So everything starts off really good, and then all of a sudden the J point right at the beginning of the ST segment does not quite make it up to the isoelectric line. It's down below. It's depressed. And then it may go on for a little bit. It may go flat, it may go down, and it may go over and up into the T wave. So this is a ST segment that is depressed. That means it's below the isoelectric line. This one over here, I'm just going to show it to you because it's here. This means they're having a heart attack. This is called ST elevation. So elevation means above. So that ST segment J point, PQRST, here's our T, but here's our J point, well above the isoelectric line. So this is called ST elevation. Some of the medics call this a fireman's hat. So if you think of a fireman's hat, how it's shaped, has a flat front with a big thing on sideways. So this would be the front, and this would be where you put your head, like you were standing sideways. So that's called a fireman's hat. It's ST elevation. So two things, EKG changes. ST depression is 8A and 8B T-wave inversion. So T-wave inversion is the T waves upside down. We notice in a regular T wave, they're upright. They're positively deflected. Over here, you can see it in a few of the leads. Here's my T wave upside down, upside down, upside down, upside down. The more deeply inverted, the more recent and more severe it is. Okay, so when you look at it, these upside down T waves, the more deep it is, these are pretty deep, the more deeply inverted it is, the more severe, more recent. Okay, let's move on to the next one. Let's look at this ST depression again. So here's the J point. It's a bigger picture. So we have P, Q, R, S, T. The J point is where the S comes down and meets the isoelectric line, right? And over here you can see PQRS, and notice the J point is well below. It's 2 millimeters, so 2 boxes below the isoelectric line before it goes off into the T wave. This is a very classic ST depression. This one's called horizontal, by the way. We'll get to it in a sec, because it's flat. So it's the J point and the ST segment is well below the isoelectric line. Okay. Rewatch it if you're not quite sure still. And then the T-wave inversion, so we have not filled in below 8C yet. We have not gotten to 8C. I'm just doing some explaining. So how can you tell if T-wave inversions represent an ischemia or a recent MI, that says? So let's put my face here. So T waves, again, if you see inverted T waves, upside down T waves, the more deeply inverted it is, the more likely it was a recent MI. And if it's just slightly inverted, that usually tells us it's some sort of ischemia. But the real tell-all is to be if we're taking a resting EKG. Now we did resting EKGs in class. A resting EKG lying down in supine position. If you have an inverted T already there in the resting position, we're going to check something called the troponin levels. And that will confirm or deny if they have any cardiac history whatsoever. Okay? Meaning troponins, and again this is later, troponin levels are a blood enzyme that you emit, your heart emits when it's had some sort of damage. So it definitely comes out when you've had a heart attack. We've had some sort of damage happen to the heart. It's like a cry for help. So if you draw blood, your troponins will be very high if you've had some sort of damage. This can happen in a major car accident too, where the airbag goes off and hits you in the chest. A blow to the chest, like in a football game. I think I talked about Damar Hamlin. I think I'm saying his name right. The football player that had a cardiac arrest. he got a blow to the chest. Yeah, I'd love to see his EKGs and his troponin levels. That's what I'd like to see. When I saw that, I was like, I need the EKG. I need the troponin levels. So troponins we only pull when we suspect some sort of heart damage. And you or I having troponin levels would be negative, would be zero, almost zero, or really low compared to anybody else. Okay? So if they're normal, if the troponin levels are normal and we have those upside down T's at rest, then it's ischemia. Okay? We will confirm it by running a stress test. So once we run the stress test, we can tell if those inverted T's become they become deeper or wider, they get worse, they get more symptoms while they're doing the stress test, then we know for sure it's ischemia. Okay? We would never run a stress test if the troponin levels were high. We've already done damage. They most likely had a heart attack. We're not going to put them into another heart attack. So if you see, just to wrap this all up here, if you see inverted T's on a resting EKG, so lying down supine, inverted T's, okay, with symptoms and stuff, we're going to assume it's a recent MI, so we're going to pull troponins. If the troponin levels are normal, then we'll do a stress test and confirm if they get worse and if they get any symptoms. If the troponin levels are high, they definitely had a heart attack. Okay. So if during a resting EKG, the T waves are normal, we don't see any T wave inversion, and then we put them on a treadmill and exercise, and then the T waves all of a sudden are upside down while they're exercising, then we know it's ischemia for sure. Okay. They'll probably have symptoms of the ischemic response, so they'll have chest pain, shortness of breath, they might get lightheaded, dizzy, all that stuff. So we are testing while we're on the treadmill doing the stress test. We are looking for ischemia. Number one thing. We will not be looking for a heart attack. We will not put them on the treadmill if we think they're going to have a heart attack. Okay. You can rewind this again. We're going to talk about it in classes too. So if it's got a little confusing to you, I'm going to review in class for sure. Oops, let me go back. My bad. All right, so these are what you're supposed to write down on your 8A, B, and C. So 8A shows ST depression, and it shows you the three different types, but we know that the J point is way below the isoelectric line, and the ST segment stays there until we pop up to the T wave. T wave inversion looks like this with the T waves upside down. They can be just slightly upside down or a little more deeply inverted, where here we can see very deeply inverted. So they can have lots of different shapes. It's just know that they are a negative deflection instead of a positive deflection when it's inverted. And then one we did not talk about yet is something called a peaked T wave. So we have a regular PQRS, and look at this T wave. It's super tall and peaked. It looks kind of like a tent or like the Eiffel Tower, something like that. So PQRS, tall T wave, usually a little wide, a little tall. It looks really weird. So a peak T wave is also an example, or can be an example, of ischemia. Okay, so these are the three things I'm looking for on a treadmill. They may not have these at rest. They may be just a normal EKG at rest, but they've had signs and symptoms while they're out walking the dog, shoveling their driveway, mowing their lawn. So we're going to exercise them as if they were doing something physical, and we're going to see if any changes happen. So we have a normal one while they're resting, and then we have ST depression, T wave inversion, or peak T's while they're exercising, and then they get symptoms with it. Put those together, it gives us clues that they have ischemia. Okay, pretty cool. All right, so these are the three different types of ST depression. Okay, they're just shaped a little bit differently. So this one is easily named horizontal because our J point is way down here and the ST segment stays flat. That's why it's called horizontal. Okay. Up here we have our J point here and the ST segment is going to slur downward. And then we see a T wave after. So this is called a downsloping, kind of like a ski slope. We have our P, QRS, J point down and then up to the T wave. The last one's called the upsloping. So we do have upsloping, so it will come down here and then it will just gradually increase. So some of them are significant and some of them are not. A natural ischemic response happens to a lot of people when they exercise, especially when you push it to their peak, okay, where you'll see this upsloping. Now, if it's a narrow upsloping where these two right here are small, it's not significant. That's a normal response. Say we pushed them to their 100% of their heart rate max. It could be, this is normal, okay? Now, if it's much wider, so this is wide, this upsloping is wide, it's the bad ischemia. I'm going to show you here in a sec. So just write that on your three things here. That's number 9. So horizontal, downsloping, and upsloping. Just know those 3 names and the difference, what they look, how they look. All right, so there's something called digoxin and a phenomenon called digitalis. All right, digoxin is a medication. It's given to patients that are in heart failure. Okay, it's a very common medication. So with any other medication that we have, it sometimes causes other things to happen. You know, you can't just have it all, right? You just can't have it all. Something's going to cause something else to do this and go crazy over here and all that, right? So digoxin is a drug. It's a very common drug given to patients with CHF. So it does help with the pacemakers, kind of gets them a little bit stronger, enhances them so that we have a bigger QRS. Heart failure patients have QRSs that are teeny tiny, and it just doesn't have a lot of ejection fraction. They don't have a lot of cardiac output, so it increases the cardiac output. All right. So once they've been taking digoxin for a while, it makes a new differentiation on the EKG. It's called a scooping. So the ST segment looks like it's depressed, but it's kind of like in a scoop. So you don't really see it as downsloping, upsloping, or horizontal. It's more of a scooping. So it creates this phenomenon. It's actually pretty cool. Or not cool, but it's cool looking. So it looks like this, kind of like a mustache. So here's your scooping right here. So some people would mistake this for ST depression just because this does not go straight across. It comes down in this scoop like a mustache. Okay, this is the digitalis effect. So it's hard to tell if it's actually ischemia or if it's digitalis caused by digoxin. Digoxin is the medication. Digitalis is the effect that happens on the EKG. Again, we'll just have to do more tests, right? We're just going to find out. We'll do a stress test. So here's a couple more examples of what digitalis looks like. And you can see scooping right here. Here's a scooping. Here's a scooping at the bottom here. So it kind of looks like downsloping into a scoop. And this is a definite scoop. And on the EKG down here, you can see scooping, 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 scooping. It doesn't happen in all of them, but a good majority of them have that little scoop. So again, the digoxin is the medication. Digitalis is the scooping phenomenon that happens on the EKG. Okay, just something to be aware of. All right, so injury to the heart. So any injury to the heart can be caused by some sort of blow to the chest, tears or ruptures in the heart muscle wall, heart valve issues, heart attacks, so obviously actual trauma like a car accident, like I mentioned earlier, like our football player that got a blow to the chest. Any of those can happen, okay, can cause injury to the heart. So if we have an injury to the heart, we are not just don't have just a block, like a narrowing of the blood vessels, we have now a blockage. And there is no blood supply getting to that certain area of the heart. This is bad. Ischemia we can live with, we can work with, because there's still blood flow getting there. It's just working harder to get there. Blood pressure might be raised. We get a few symptoms like some chest pain. This is where there's a total blockage. We can't get through. So I don't know about you guys, but when my pipes clog in my bathroom and because of all of my hair that goes in the drain, you have to get the blockage out because the water will not drain, right? Blood will not drain. Blood will not go where it needs to be. Bad thing. Okay, so EKG changes in the limb leads. So that's our leads, Roman numeral 1, 2, 3, AVR, AVL, and AVF, those 6, right? In our limb leads, if you see 1 millimeter or more of ST elevation, so that's one box, right? 1 millimeter or more in the leads in the same region of the heart, then we have an MI. In the precordial leads, so in leads V1 through 6, it needs to be a little bit taller, 2 millimeters or more ST elevation, and at least 2 leads in the same region. So what does that mean? So this is an MI, so this is some sort of myocardial infarction where we have a blockage. So that means that if I were to have ST elevation in limb lead 1, that's the lateral region of my heart, right? Lead 1 goes across the body, it lands on the left arm, that's the lateral region. The other one that goes with lead 1 is AVL, because AVL also lands at the left arm. So AVL is left and lateral. So 1 and AVL go together, and we've done this before. It's the regions of the heart. So if I find ST elevation of 1 millimeter or more in leads 1 and AVL, it is positive for a heart attack. Okay? If I find in leads 2, 3, and AVF, those are our inferior leads, right? Leads 2, 3, and AVF, those 3 go together because they all land at the foot, the left foot. Lead 2 goes across the body, lead 3 comes left arm to left leg, and AVF goes here and to the foot. They all land at the foot, inferior region of the heart. So if I have lead 2 and lead 3 have changes, but AVF doesn't, it's still counted as diagnostic. Okay, so we had 2 of the 3 have changes. That would be a yes to inferior region of the heart. There would be a MI in the inferior region of the heart if we have 2 leads that have it. Now, if you only have 1 lead that's different in that region, so out of 1 in AVL, if only 1 of them has change, it's non-diagnostic. Same with 2, 3 in AVF. If you only have 1 lead that's changed, it's non-diagnostic. You'd have 2 that match. So in leads V1 through 4, all of those are anterior, right? V1, 2, 3, 4. All of them are anterior region of the heart. Some are right septal and left septal, but it doesn't really matter. It's all anterior. I need to have 2 of those that have changes to make it diagnostic. So I might have a change in V1 and V4, but it's all anterior, so I definitely have a change, so I have something happening in the anterior region of the heart. And then apical is V5 and V6, so both of those would have to have a change. So something called a reciprocal change is if I have something going on up here, I will have just the opposite going on down at the bottom. So whatever's happening up top should be just the opposite down bottom. That's just the way it happens. Everything's opposite, right? So if I have ST elevation on one side of the heart, you'll have ST depression on the other side. So if I have inferior ST elevation, so 2, 3 in AVF, I have ST elevation in 2, 3 in AVF, then up top in the lateral region, 1 in AVL, I would have ST depression, just the opposite. I'm going to get into this more in a minute. And then if I have anterior elevation, so in V1 through 4, I may have depression inferiorly because it's down below. I'm going to show you a chart that has all this in here. I'll make it make more sense. We'll also go over this in person too. Okay, so an infarction is the definition of infarction is death of tissue, necrosis, right? So it's due to the lack of oxygen getting to that heart muscle tissue. So a myocardial infarction is literally a heart attack. It literally is death of heart tissue or heart muscle. Myo is muscle, cardial is heart. So myocardial is heart muscle. An infarction in the heart muscle is a heart attack. So that's where myocardial infarction comes from, or MI. So basically what happens is wherever that blockage is, it's a total blockage. So if I have a blockage right here in my heart, now all the blood vessels below that are not getting blood. Therefore, they're not getting oxygen. So this part of my heart gets starved of oxygen. When it doesn't have oxygen, it's killing the heart muscle. So necrosis, it just literally means death of heart tissue. Infarction is death of some sort of tissue. Myocardial is the heart tissue. So it means death of heart tissue. This is just a very similar picture here where the blockage is here. Anything below it is dying because it's not getting enough oxygen. Yeah. Not good in your heart. Not good, right? Okay, so the different types of MIs, there are 3 basic types. Yes, there are different types of MIs, I know. So an AMI is just an acute myocardial infarction. So acute, in anything acute in the medical field means it's happening now, suddenly, it just happened, okay? And I think of acute in mathematics is, acute is a small angle, right? So acute in medicine is a small amount of time. Okay, it happened suddenly, it just happened, it's happened recently. A STEMI is a type of MI, of a type of AMI. So it literally stands for, these letters stand for ST elevation myocardial infarction. ST elevation myocardial infarction, okay? It means that it's telling you exactly what's happening. We see a definite change in the ST segment on the EKG. It is elevated. So ST elevation myocardial infarction. We'll see that on the EKG. We'll see that ST segment well above the isoelectric line. You can see this picture down here. Here is our J point. It's way above the isoelectric line. This is a STEMI. Now an NSTEMI is a non-ST elevation myocardial infarction. They have no ST changes. So I hook them up to the EKG machine. They have no ST changes on the machine. They're having all the signs and symptoms of an outward heart attack, but I don't see anything going on the EKG. It looks fairly normal. So because they're having all these symptoms and it looks like they're having a heart attack or possibly having a heart attack, we're going to go ahead and pull troponin levels. We're just going to pull the troponins, those enzymes that are found in the blood, and see if they're normal. Okay, so if they are normal, they will be way, way down to 0.01. If you move the decimal point over, sometimes they do it in the millis. It might be 10, which is normal. Okay, so troponin is that enzyme that the heart emits only when it's undergone some sort of damage. And our normal troponins are way below. They're in the zeros range. Okay, so if we see some sort of damage and no changes on the EKG, this would be an NSTEMI. I actually had one yesterday in the ED. I worked in the ED yesterday, and I had an NSTEMI. This gentleman was 73 years old, in fairly good shape, in actually workout clothes. He was with his daughter. They were at the gym working out. He has no heart history whatsoever. Doesn't take medication for blood pressure. Takes no medication at all. No blood pressure, nothing. No family history, nothing of a heart attack, nothing at all. I take his EKG. It actually looks somewhat normal. There's a little, like one lead that looks like might be a little different than the rest, okay? And again, remember, one lead is non-diagnostic in the real world, right? So the doctors were like, it's kind of wishy-washy. It's only one lead, blah, blah. I said, yeah, but he looks bad and his story sounds bad. So he had like this gray color and he was very diaphoretic. So that's that sweaty, clammy look. Not the good sweaty like you just worked out, but the clammy, sweaty like I'm really sick. And a gray look in his face. And he said his chest just doesn't feel right. It hasn't felt right all day. He's had 2 episodes of these real sweaty episodes where he has to stop what he's doing, gets sort of breathless, lightheaded. Okay, not severe chest pain. Just doesn't feel right in the chest. So I didn't feel right about this. I had to make sure they got him back to a room in the ED pretty quickly. The doctor was kind of wishy-washy about it. I'm like, he doesn't look good. I think he needs to go back. So we went back, took the troponin levels through the roof, over 100. So, it was bad. So he definitely had an NSTEMI where we saw no ST elevation, but he had all the signs and symptoms, and then we checked the troponin levels, and it was high. So, needless to say, did not go for stress test. He went to the cath lab to see if he needed stents. Yeah. Real stuff. All right, so let's take a look at these. I guess let me go back real quick because I didn't show you this. This right here is a regular EKG, and we can kind of, I don't know if I can move this. I don't think I can. I can't move that bar. So I would look at, when I look at an EKG, automatically I look at the regions that go together. So I automatically go to 1 and AVL. They go together. Okay? That's the lateral region of the heart, or it represents the lateral region. And I can see that this is my isoelectric line and that my ST segment, my J point, is above the isoelectric line. And it is about at least 1 millimeter. So I'm going to say he's having, and it's in both of them, Do you see this? Where this is the isoelectric line and this is above it. Isoelectric line above it. So I'm going to say he's having a STEMI in the lateral region of the heart. Okay, that's my first guess. I'm going to look at the other ones too. So down here in 2-3 Navy F, since this is the bottom of the heart, I should see either inverted T waves or ST depression. And now this doesn't look any different, but down here it does. There's ST depression here and here. See the depression? So this confirms, this is reciprocal changes. This confirms that this is definitely a STEMI. Now, he can have a STEMI in more than one place of the heart. So we're going to look at all of the regions. So our V1 through 4 is also a region. And I can see that this is a very tall T, but look at my J point up here. It's elevated. My J point right here, way above the isoelectric line. This one here, way above the isoelectric line. Way above, way above. So he's actually having a STEMI in a couple different areas, anteriorly, laterally, and apically. So he might have 3 different blockages that we need to find out. This EKG is so helpful to the cardiologists when they got to go in and kind of figure out where the blockage might be. It's telling you on the EKG where the blockage is. So they can snake in and go in there and look at the x-ray, find the blockage, and get it taken care of rather quickly. Okay? I'm going to show you more, so don't worry. All right, so here are some different stages of an infarction, basically. This is some different stages, okay? So when someone is about to have a heart attack, okay, a full-blown one, you're going to start to see a small elevation here, and you're going to see the T waves get a little bit taller and peaked. So this is a peaked T wave, a hyperacute peaked T wave. The hyperacute ones are wider than the regular T, like the peak T's for ischemia. This is going to be a wide one, and you're going to see this J point elevated just a little bit. When they're in a full-on middle of the heart attack, this is ST elevation, and you can see this is my isoelectric line. My J point and ST segment's way above that. This is ST elevation. This is right at the height in the middle of the heart attack. The heart attack starts to come down, and we can see that the elevation is also coming down, but now look at the T wave. The T wave is becoming inverted. Inverted T wave can mean a recent MI, right? So this could mean it just happened a few hours ago, it happened a few minutes ago, it happened last week. So over here, once we've come out of that STEMI, that ST elevation, we're left with an inverted T. This is the final aftermath, if you will, of a heart attack, okay, of a STEMI. So inverted T waves, if they're deeply inverted, usually means a very recent MI. This happens all the time, by the way, especially when it's like we get our first snow and people need to shovel their driveways, or it's the first time to cut your grass and they've been sedentary for a while and people get out and start to move and do things physically, and they're like mowing their lawn and all of a sudden like, whew, I have some chest pain, I gotta sit down, I'm real short of breath, I don't know what's happening. It passes 10 minutes later, they feel better, they finish their lawn. This happens, I'm not kidding, this happens all the time. And then in the next couple of days, they're like, you know what, since I had that chest pain, I just don't feel right. I'm a little lightheaded. I'm kind of short of breath. Maybe I should get this checked out. They come to the emergency room. So they were mowing their lawn on Saturday. They come on Tuesday. They lived with this for a few days. Come on Tuesday, hook them up to the EKG. They've got inverted T waves all over the place. Okay? They had a heart attack on Saturday while they were mowing the lawn. And then finished the lawn. And decided to come to the emergency room 3 days later. Okay, so again, that sounds crazy, but it happens all the time. I'm not kidding. Not kidding. I see so many that happen that way. Yeah, crazy. Don't let your relatives be that way. Someone's having chest pain, go to the emergency room. For sure. Okay. All right, so here's the evolution. Again, just one more way to break this down. There's a new star in there, though, the red stars. We haven't talked about that yet. So this is just kind of reviewing what we just talked about, where we have a normal EKG. So A would be a normal EKG. B, if you want to put the star up there on yours and name it the hyperacute peaked T, peaked, P-E-A-K-E-D, peaked, hyperacute peaked T. That's our first phase, right? Second phase is full blown on ST elevation. That's where the star is. This is your ST elevation, your STEMI, where the ST segment is way above the isoelectric line. From here, we're going to start to come back down. They're going to start to feel a little bit better. You're going to still see a little elevation. Now you're going to have an inverted T. So what has changed with this red one? We have not labeled this yet. This red star, notice up here, our QRS sometimes the Q goes directly into the R, or if it comes down this way a little bit, it's very small. It's very narrow and skinny and not very deep. The Q wave is usually small and narrow. Once we've had a heart attack, okay, that's going to change the look of that Q wave. The Q wave is going to get wider and deeper, okay? It's subtle. Don't think it's going to jump out at you. But once you've had a myocardial infarction in that region of the heart, you will have what's called a pathological Q. Pathological, so it's path, P-A-T-H-O, logical, pathological Q. So that means this Q wave is going to get deeper and wider. Okay, it's a permanent scar. It stays there forever. So once you've had a heart attack, I can tell you had a heart attack 5 years ago, and I can tell you where you had a heart attack by the EKG. So once we've created the damage, you're now going to form this pathological Q. We are in the inverted T phase. Over here, we're in the inverted T wave. So this is just a few hours after. This is a few days after the event. Pathological Q has been formed. And this is after the event. This could be weeks to years after the event, and you would still have a pathological Q. Crazy phenomenon, right? I know, it's crazy. So when I look at your EKG and I'm like, hey, you've had a heart attack before, I can tell. I can tell where. It's subtle to you guys. It's going to be hard to see until you're trained on what to look for. So we'll do that in class in person. It's subtle. All right, so hyperacute T waves. We're almost done with this section, guys, and then you can take a break. So the hyperacute peak Ts. So they resemble a tent or a mountain peak. I kind of had told you this before already. They must be at least 2 big boxes high, so 10 millimeters in height. So 1 box is 5 mils and 2 is 10. Yeah, so when we're talking about height for ST elevation, 1 mil is 1 tiny box. So that means that's not very tall. This is very tall. This is 2 big boxes. So these are hyperacute peak Ts. They're very tall. They come after the QRS. If you're not sure if that's a QRS or a T wave, just follow the P wave. Find the P wave. Here's the P wave, QRS, T. P wave, QRS, tall T. And they're all more than 2 boxes high. Okay, so we can take a look at this and we can see that there's some peak T's going on here in the 2, 3, 4, 5, and a little bit in 6. So what region are we having these hyperacute peak T's? It's going to tell us where we're either having ischemia or the start of a heart attack. And if you guessed anterior and apical, you are correct. V1 through 4 is the anterior region of the heart, and 5 and 6 are the apical region. So that's telling me I have some sort of narrowing happening in that region of the heart. Hopefully it's just ischemia and it's not leading to an MI, but we don't know the difference because if they're already having chest pain, we're going to pull troponins and figure out where we go from here. Okay, we have to act rather quickly on this. I might even do a repeat EKG on this in about 20-30 minutes just to see if this has changed into the STEMI criteria and if any of those symptoms have worsened. Okay. All right, this is where we're taking a break. So I'm going to stop the video here. This is your part 1 of Unit 2, Lesson 2 or Module 2. And your next video will pick up where we left off. Always rewind, send me a message if you're not understanding, can't figure it out, want to rewatch it again, all up to you. Otherwise, I'll see you next video. Bye.